Very good afternoon, everyone, and lovely day in Amritsar. So I'm going to share with you the results of the study that we have been doing at my center, Medivision Eye Hospital. Now, we know that corneal endothelium is obviously crucial for maintaining a clear cornea. And a turbulent or uneventful or even eventful cataract surgery, it is one of the most affected things at the onset. Now, preoperative assessment of an endothelium carefully will help predict postoperative outcomes, especially in the borderline cases. Now, the question is a specular microscopy to be done routinely in high volume cataract center or not? Now, the specular microscopy traditionally will give you an endothelial cell density, morphology, hexagonality, and early detection of any guttata or other changes. Now, traditionally it is linked to prolonged corneal edema. Low endothelial cell density or a large area is linked with prolonged corneal edema and a delayed visual acuity. So, delayed visual recovery. So, number of studies have been done trying to correlate with how much of endothelial cell loss happens actually during a routine uneventful cataract surgery. Now, starting from what the residents are performing, that is 20% endothelial cell loss during surgery, to enhancing chopping techniques, that is evolution from stop and chop to direct chop, and also to being used by a senior surgeon, wherein the senior surgeon understands that which technique is best for which grade of cataract. So all these studies have been published, and we know that a particular level of endothelial cell loss, anything between 5 and 15%, is fine. Now, our hypothesis was that a preoperative specular microscopy in a high volume center will allow tailoring of the surgical technique, that is lower parameters, use of viscoelastic devices, and lead to parameter outcomes which are comparable to those with a normal endothelial cell density. So our primary objective was to compare endothelial cell parameters between patients with good versus poor visual outcomes on post-op day 1. And secondary objective was to understand if the baseline low endothelial cell density predicts achieving a good visual outcome or not. So we started off with this, that if the patient has very good visual outcome after post-op day 1, that is 6/6, then probably his endothelial cell parameters are good. So the study design was a retrospective observational study. Period selected was between January and December 23, and all patients who underwent routine phacoemulsification and had a specular count done were included. And we analyzed 100,550 patients, and all the patients with missing records were excluded. So in all, 1,546 were included. For the outcomes, we defined poor visual outcome as anything on post-op day 1 worse than 6/18. So anything less than that is categorized into the poor visual outcome. And a good visual outcome was anything between 6/6 to 6/12, unaided or best corrected. Now, endothelial cell density, low endothelial cell density was first defined as less than 2000, but then on sub-analysis we realized that probably 2000 was too high, and therefore we classified into less than 1700 to more than 1700 density. And NIDEC specular microscope was used, and a minimum of 3 images which were clear and were included. And the parameters recorded in the data sheet while collection was endothelial cell density, mean area, standard deviation, percentage hexagonality, and any additional abnormalities that were noted during assessment of the image itself. Surgical protocol was redefined as per the count, and anything with a low count, that is less than 2000, or with gut data or with a high cell area, was then subjected to special techniques of use of viscoelastic devices, cohesive and dispersive in a soft shell technique, and as well as ad libitum, and a viscoelastic filled device chamber entered before every step, that is even before irrigation and aspiration, the chamber was filled with viscoelastic device. Slow phacoemulsification was done, and direct chop technique or technique modification based on grade of the cataract was done. 2 surgeons remained constant throughout the period of the study, and additionally also the demographic data, clinical correlation, any other comorbid conditions were also documented. Particularly, I'm going to mention about visual acuity handling because we converted all the data into logMAR and published whatever the published literature was. Based on that, counting finger, 2 meter, 3 meter, 1 meter, hand movement, PL and no PL were categorized based on the published data, because this is not available freely. Statistical analysis was done, and we also, because the data set was very large, 1500 cases, and the data set with lower endothelial cell density or with lower visual acuity was far lesser than the ones with high. Therefore, we studied, number one, we looked at the data whether it was a normally distributed data or not, and then looked at the homogeneity of the data. And once it was found to be non-homogeneous, we subjected accordingly to Welch t-test. So this is the age distribution, female ratio, laterality is comparable, preoperative visual acuity less than 6 by 16, 886 eyes, again very well distributed, and less than 6 by 60, 658 eyes. Now, and if you see the endothelial cell density histogram between the cases with poor visual acuity on post-op day 1 versus good visual acuity on day 1, even eyeballing it, you will think that it is well equally distributed in both the groups. Despite that, the number of cases in each group is very different. The Levin's test was done for the homogeneity of variance, and we found that the poor visual acuity versus good visual acuity, there was no difference between the two groups. So at the end of the extensive statistical calculation, we had some very interesting findings. Number one, that endothelial cell density between a poor visual acuity and good visual acuity group, there was no difference actually. Post-op visual acuity between endothelial cell density in groups less than 2000 and more than 2000 was also not different. Again, subclassification to less than 1700, also there was no difference. I'm sorry, there is a typo here. And the incidence of 2020 was in fact more commonly found on post-op day 1 among the marked cases, that is those with either low endothelial cell density or with good touch changes. So additionally, 119 patients, these are the numbers, 119 patients had less than 20 by 80 visual acuity. Who had less than 20 by 80 had edema, and PCR was less than 0.01%. Post-op keratoplasty was not required in the given subset in any of the cases. 52 cases of corneal guttata were additionally discovered at the time of preoperative assessment. So to conclude, we found that surgical modification in the borderline cases actually gave to superior results post-operatively, and no case in either group required keratoplasty at the end of the follow-up. And this is important because in a high volume busy setup, it is very easy to miss out the subtle problems in the cornea, especially good tape changes. And therefore, we think that we feel that routine assessment has given better outcomes. Additionally, the chondroitin sulfate that is used in viscoelastic devices, I think that there may be some basic research required here, but it's actually helping the endothelial cells function better when it is being used, especially in these cases. Thanks to Dr. Ravi Kumar Reddy, whose foresight and investment in the specular microscopy. We have been religiously doing the specular microscopy for the last almost 10 years in all the cases, and that has given very consistent results and very predictable outcomes even in the lower cases.
Thank you very much, Charuta. This is a very exhaustive, excellent study and great presentation.